Sherlivia Parker, currently the CDI unit manager at University of California Medical Center, Davis. We've known Sherlivia for over 10 years, so it's been an honor to kind of get a chance to introduce her. She has her master's degree, health administration from University of Phoenix. She also has her bachelor of science in health information management from University of Louisiana Lafayette. Uh, she's 19 years within revenue cycle experience, various roles: HIM director, CDI physician educator, clinical auditor, coder auditor, excuse me, CDI specialist. Really fantastic as it relates to denials management. She's going to be kind of joining us on our next event on the denials panel, and then kind of turning it over to Reggie Allfield. Was born in Missouri, began his nursing career primarily in the ICU. Works at the University of California Medical Center at Davis. He began in health informatics in 2011, with his prior hospital health system, and really was tasked with implementing, their EMR, electronic medical record, and worked both on the design and implementation side. And I think, for his presentation piece and kind of what he gets into, kind of ties all that together, which is really fantastic during this presentation. He received board certification in nursing informatics in 2016. Is presented, at the American Nursing Informatics Association Academy and in other venues as well. And his educational background in nursing and health informatics and business administration, and like I said, just gives a really good tie-in to kind of where the program has started and what that data is and kind of how that incorporates to everything within their current program. So, without further ado, Sherlivia and Reggie, I turn it over to you. Thank you all very much.
Thank you so much, Chris. It's a pleasure for us to be here as well to share our experience in the outpatient CDI arena. As you said, I think hopefully our goal with this presentation is to give you some insight on key things that you can think about if you're thinking about launching your outpatient CDI program in regards to workflows, automation, and key performance indicators. So today our learning objectives are to understand the importance of outpatient CDI and the impact beyond the outpatient clinic environments, understanding hierarchical category conditions and what these categories means and how they can impact your overall outpatient CDI program, access your organization's infrastructure and identify key stakeholders to ensure the success of your program, apply workflow and best practice recommendations and employ strategies for continued success. So we wanted to provide this disclaimer because we will go over some tools that we utilize in our program today. And of course, we're not endorsing any project, but merely we just want to share the tools that we have used to fine-tune our process to streamline our outpatient CDI workflow and ultimately to automate our workflow. Tableau is one of the tools we utilize today that provides us complete automation in the outpatient CDI arena. This actually goes through the abbreviations we will use throughout the presentation for your reference. Next slide. So before we get started with going through our outpatient CDI program, we wanted to start with giving you an understanding of the UC Davis structure. And I think that's important to go over, especially when we're looking at our total clinic visits and facts and figures about UC Davis. It'll help bring in or hone in on how we actually broke down all of these key components so we can ensure the success of our outpatient CDI program. As you can see, CDI sits underneath health information management, underneath the revenue cycle. And we've honed in a bit on our outpatient CDI structure. We currently have 10 FTEs when it comes to our CDI review team. In the outpatient CDI arena, we have a supervisor and of course a manager as well. And as you can see, we have clinic and then we have an ED CDIS on the outpatient side, in addition to our CDIS/analyst as well that assists with some of the creation of these tools that we utilize to automate our. So as you can see here at UC Davis, we nearly have 1 million scheduled clinic visits throughout a fiscal year within our organization, and we have a 93% attendance rate. So that just kind of shows you the sheer volume that we're looking at when we're looking into our outpatient CDI program and what patients we wanted to actually hone in on and review. And then looking at the big picture, first looking at volumes, and then next trying to hone in about which population that will be impactful for your organization. So the patient population that we focus on is our Medicare Shared Savings patient population, and that's our MSSP patient population. We have nearly a little over 22,000 patients that sits into that category. These are the patients that we actually focus on from a review process. We just received a new upload, and we currently have about 23,000 patients that's in our MSSP patient population. So our telehealth visits here it's also a part of our overall scheduled clinic appointments, and that's a little over 156,000 for our calendar year 2020. And then our ambulatory surgical center is a little over 13,000. So our overall staff here at UC Davis is close to 12,000. And then our physicians, our faculty that actually sees patients is almost 13,000 physicians. So you can kind of get an overall big picture understanding about our total staff here at UC Davis in line with our physicians as well. So now we want to dig in a little deep and kind of talk through how you would establish your program. We're talking about outpatient CDI and what constitutes the importance and the needs of the program and their impact. So this particular slide here represents how HCCs is really impactful across the continuum. So it doesn't matter where a patient is within your organization, within any of these actual categories, if an HCC is captured, it will impact the overall severity of your patient. And so that's important to look at when you're actually establishing your outpatient CDI program and how those reviews actually take place. Within our outpatient CDI program, our team really does a very good job, their due diligence to actually comb through the chart and ensure that the HCC was not captured within that calendar year before sending a query. And that is very important for the success of your program and thinking through how that can be done. Right now, it's a manual process that we do in Epic, but we have access to all of the charts and documentations for patients so we can see if an HCC was captured. I also want you to think about our inpatient versus our outpatient environments. I know in some organizations, our inpatient CDI specialists may query for HCCs because we don't have an outpatient CDI program. And I think it's important to think about that because should you actually launch an outpatient CDI program to focus more on those HCCs and ensure that we are not over querying and we hone in on those opportunities for HCCs. This slide here represents all the categories of HCCs, and the category that we have chosen to focus on is our accountable care organizations, which is our MSSP patient population. But if you look at all of these categories here, this slide should help you think about what areas in your organization can you partner with other stakeholders. Population health is really big today in acute hospital settings. So how can you partner with your population health stakeholders and find out about your hospital-based purchasing initiatives, your readmissions, and how can you guys work together to establish a patient population that your outpatient team can review to adjust for risk adjustments. For us, we use our ACOs, but this entire group, our categories for HCCs, are ultimately here to help you hone in on the patient population that will provide the biggest bang for your buck at your organization. So this slide here, we wanted to bring forward some statistical data that CMS actually has published to look at how impactful is HCCs? And again, as you're talking to your executive suite, I think this is a key slide that can be used to help them understand the importance of HCCs and the financial impact it can have overall. I mean, as you can see in this slide, in 2018, 90% of fee-for-service was linked to quality. So our categories 2 to 4 that we just saw in those previous slides. So again, if it's linked, if our fee-for-service is linked to these categories, that means for calendar year 2020, your organization would have received a plus or minus 5% of their overall payments when it comes to their MIP scores for these categories within 2 to 4. And so I think this slide really brought it home for me to establish the importance of really honing in on outpatient CDI and finding a way to allow your executive team as well to understand the importance so you can capture effectively HCCs and above all, the ability to measure those. So now we want to talk a little bit more about the importance of, or the components of our outpatient CDI program. This is arguably one of the most important components you all will have in your outpatient CDI program. Otherwise, who will be reviewing the chart? So how did we choose our team? I think we've read a lot in some of the recent Actis articles about diversity in CDI teams and having different levels of specialties coming through for your team. And so we'll talk a little bit more about that in the structure of our team. So this slide here represents our CDI team and key stakeholders we want to tap into. One of the things that we've done very recently as we were honing in and fine-tuning things and areas that we could improve, we actually evaluated each of our stakeholders and how we could partner with them a little better and bring them into our world and understand their world. And so if you look at this graph here, these are all of our stakeholders. That is actually, we're tapping into these stakeholders every day and every minute of the day. So our clinic and our ED team leads, remember, we're sending these queries as a CDI professional, but we're not coding these HCCs. So we need to ensure that these clinic leads and managers know what we're doing to ensure the ultimate capture of an HCC. And how are you measuring that and partnering with your stakeholders is something you really have to think about to ensure the success of your program. How are we partnering with our physicians? I mean, when we're looking at clinic environments and partnering with physicians, we need to think about the structure in a clinic, right? I mean, in a clinic, when these physicians are receiving our queries, they are seeing patients all day long. And partnering with our physicians and even our clinic managers, we learned that when a physician comes in when it's time for them to start seeing their patients, before they actually, as they are preparing to see their patients, they are talking with an MA and a nurse, and they put key things on the whiteboard for these physicians to complete by the end of actually seeing the patient or by the end of their day. And so one of the things we were able to add to that whiteboard as the physician is interfacing with the clinic, the nurses and the medical assistant is their pending queries. We have a physician advocate team that actually will go out and do the shoulder-to-shoulder education for our physicians and how to answer a query in Epic. And ultimately, our population health team, I just cannot speak enough about how important this team truly is. We talked a lot about which patient population, that's our focus here at UC Davis, and the entity that oversees our MSSP patient population, ensuring that those patients are provided to us is our population health team. And this team oversees a lot of different areas depending upon your organization. So if you don't know who the key leaders are of your population health team, especially in the acute care setting, you want to get to know them because they are that big piece in ensuring you can get the right patients to review for whichever category you choose to focus in within your outpatient CDI program. All right, so this is talking about our CDI team members, and those are truly our key internal stakeholders. If they do a great job in reviewing these charts and communicating with physicians and sending these queries, that is the beginning and the success, right? And so picking the right team and a diverse team with diverse skill sets has, I think, truly been one of the key components of the success of our program. Here at UC Davis, we have coders, nurses, we even have a social worker that's a part of our CDI team, and sending these queries for our physicians. And I think I read an article recently, even in Actis, promoting the diversity of CDI and the value that brings to an overall CDI program and the success of that program. We're even currently training a ED coder who has a nursing background into our CDI program. And one of the key, the feedback that I got from actually the CDIS who is training her is that she brings a lot to the table because of that ED coding background. And then, of course, even on top of that, she has been a nurse, or she is a nurse. And so thinking about all these things before you launch your program, if you have not, or if you currently have a program, how can you be more diverse and get the very best people to do the work? Because that truly ensures the success of your program. So we talked a lot about our key stakeholders when we were looking at the diagram earlier, and we wanted to share a little bit more about the pearls to success as we engage with these external stakeholders. That is a true part of our process, and at least a big picture part of our success of the HCC capture. One of the things that I found very interesting and actually educational for me when I started engaging with our clinic managers is that you shouldn't ever assume that they know your role, right? When I called the clinic manager the first time, I was trying to partner with her because we had a large volume of unanswered queries for this particular manager's clinic. And when I initially called her, she thought I was calling about her RAF score, and she was 100% aware of her RAF score and some improvements she needed to do there. And I was like, no, I'm with CDI. And she was like, okay, what do you do? How are you impacting the RAF scores? What's your role in capturing the HCCs? And even though initially when outpatient CDI was launched, everybody was trained, we talked to everybody, they know about us. But I always say out of sight, out of mind goes a long way. As time progresses, and if we're not engaging with them constantly, then we can be forgotten. And so one of the biggest things here is that we started engaging ongoing and real time. And one of the things that has always been done historically is working with our coders to ensure that our HCCs were captured. One of the things that we learned with our clinic coders and their leadership team there is that when they implemented a new tool, when they implemented 3M, our queries were actually not flowing to that 3M product that the clinic coders were using the code from. And so we implemented an automated process so that we can provide to the team leads a list of pending queries for their clinics. And again, had we not partnered and start asking the right questions, we would have never known that they were not seeing our queries. And that's why a large amount of our HCCs from a coding viewpoint was not being captured. So understanding the workflow in these clinics is key to the success of your HCC capture. And the same goes for the ED setting. These settings works very differently in our organization. But again, we understand from a big picture viewpoint, how they both work, how we need to connect with them to ensure that our HCCs are captured. And then ultimately, we're always thinking about how can we automate our processes to ensure that we can engage with them and it doesn't have to be a manual process. And always within any CDI program, it doesn't matter if it's outpatient CDI or inpatient CDI, physician engagement is always key. and always trying to figure out ways to have CDI talked about continuously. It doesn't have to be with a CDI manager per se, or even CDIs. You know, we're talking a lot about other stakeholders that's a part of your process. And when I started engaging with the clinic managers recently to re-engage with them, should I say, one of the first things they asked me for was, do you have a tip sheet? Is there something we can use to remind our physicians how to answer your queries? Because even though we've educated them, we have our physician advocate team who can re-educate them. It's important that we all understand the process from a big picture so that we can help each other and help a physician navigate through that process. So these are some of our physician engagement pearls that's utilized here that we wanted to provide to you all. And just having the ability, something tangible to share is vital. Here at UC Davis, our physician advocate team created a video. It's a 5-minute video. When we were re-engaging with the clinic managers, I was able to easily share that. The clinic manager was so grateful and shared with me how she was able to listen to it. She resent it to all the physicians to listen to again. Because again, if we don't get a lot of queries or if we don't do something every day, it can be easily forgotten. So these are some of the key engagement tools that we use. And then our workflow. So again, our stakeholders and engaging with these stakeholders are not just about sending the query, right? So sending the query is one piece, ensuring capture is another component. But one of the things that we did do as we were engaging with our clinic managers, I've talked a little bit about how we automated some processes to ensure that our clinic managers knew what our pending queries were, or even in the ED setting, it's a bit different because those are actually ED appointments that are not planned, of course, or scheduled. But there needs to be a way where we can have a check and balance to ensure, number one, that they know we sent a query, and number two, was it captured? So in our clinic visits, because we do prospective reviews, our team actually will send queries 24 hours in advance, and we send a list of pending queries to these clinic managers. We are aware of their coding time window and how long we need to and how long we have to actually keep a query pending. But again, all of how we look at these measures are currently automated within our processes. And so we were able to look at these key pearls here as we were fine-tuning our process and finding ways to automate. And so these are some of those areas we have outlined here. And so our workflow, establishing a concise workflow, of course, is key. So our FTE allocation and aligning patient volumes. We look all the time at our different clinics that we're sending our queries to, aligned with our MSSP patient population and what our volumes are there. Which clinics do we need to focus on, because our heavy hitters are our internal medicine family practice physicians, and then what clinic settings across our organization they are in. We looked at productivity. We did time study after time study, because remember, we're talking about only sending queries to HTCs that have not been captured within that calendar year. And we're looking at charts across the continuum because we don't want to query on something that has already been captured. So we did several different time studies to actually look at what our productivity measures are or will be. Currently, our outpatient CDI team is required to do 20 reviews in a day. We have done time studies that we were looking at increasing that a bit, but these tools here really help us understand and establish some key performance indicators for our team. We monitor key performance indicators such as our unanswered queries, our agreement rate, just the traditional things that you typically do for CDI, but there was nothing really automated, right, for outpatient CDI because it's new at one time. Now we have a lot of tools that's in play that we can use. But when we were looking at how do we capture our data and key performance indicators for our executive suites, we did look at from a database viewpoint, where we're going to house that, and what are we going to use to do that. And we use Tableau here, and you'll see some of our screenshots of how we utilize Tableau. I was sharing with Chris as we were preparing for this presentation here that I didn't know all of the things that Tableau could do till I came here. And I always say the key to knowing what a tool can do is asking the right questions. And hopefully throughout this presentation, it'll be food for thought for you so that you can go back in your organizations and ask those right questions to help you understand what the tools you may currently have, what they can truly do for you. And of course, as we honed in on workflow, we did provide a training manual to provide more ease of training our new employees.
Woo! All right. Thank you for that, Sherlivia. I bet you guys thought I was never going to talk. So I'm going to dig into the data review, and we're going to talk a lot about how we capture data and how we use our data. But before I tell you where we are, I need to tell you where we were. So initially in our team, as Sherlivia was saying, there's 20 some odd thousand people that are on our MSSP population, and they were evenly divided amongst the team. So each person had a few thousand people that they were responsible for. And they would try and go into each of those charts and then record whenever the next visit for that person was. Now you can imagine how long that could take when you've got several thousand to review, and then you have to resort your Excel file that you're using for that, and then try and open that chart before that visit occurs. And you can also imagine how many times somebody has an appointment scheduled and then something happens and they go in sooner, and so that other appointment gets canceled or shuffled around and that sort of thing. So it's not the most efficient method of how to look at these charts. So we started thinking about it, and this is one of those, what questions do you want to ask, like Sherlivia was talking about. So we decided, okay, we've got an opportunity here, and anytime there's opportunity, you can also incorporate scalability into it. And scalability just means that when you're designing something, you're designing it with the idea in mind that if I design it correctly, it can expand or contract as necessary for whatever I'm doing. And it's something that's always important to do on any type of project that you're doing, at least in my opinion. So now our current state is that we have a spreadsheet with all those patients on it, and we join it to data. Now, this required some partnerships. We had to talk to somebody that could write in SQL. I don't actually do that. I'm a data guy, but I don't write in SQL. So I had to find somebody, and I had to talk to them about what we wanted. And I knew that visits were scheduled in our EMR, which happens to be Epic, but they're scheduled in any EMR, I'm sure. And so I knew that those were in there, but what I didn't know is, how do I tell if those patients are on our MSSP population? Well, I didn't really have a way to do that. But what we did have is that MSSP list of those 23,000-ish patients. And we know that we can do joins in Tableau. And a join is, in layman's terms, you take two different sets of data that have a thing in common, and you join that thing together, and it'll give you a list of those things. That's kind of just a real basic idea of it. But because I had a list of the MRNs of the patients that are on the MSSP, and I had a list of the patients that had a scheduled visit, I could join those together and say, okay, only show me the ones that were on the MSSP list. And now I've got that focus that Sherlivia was talking about. How do we focus on that particular population? Now, you don't have to focus in that way. You don't have to choose MSSP. That just happened to be the way that we chose because, you know, as Sherlivia was saying, we had something like 1 million outpatient visits, and obviously we just can't review that many. So then in the process of doing that join and that team, I also added a column where we put the CDIS name in there, and you'll see the reason that that's useful as we go, and I show some of the slides that kind of show what our dashboards that they look like and where that's used. Okay, now workflows. Shirlivia has mentioned this a couple of times. We really can't stress the importance of going through your workflows a lot. We can't stress it enough. We probably have had at least 3 final versions of each of these workflows. We got the outpatient clinic workflow and then the outpatient ED workflow. And I don't know how many draft versions, but suffice it to say, we had several. Now, I'm not going to walk you through each individual step on this, but what I wanted you to kind of get, and probably all of you guys have done workflows before, is that it gives you these swim lanes and it gives you these decision points. And what this is useful for is you can see at what point in the process certain things occur. It's very useful for things like the comparison between the clinic workflow and the ED workflow, for instance, when the query is sent on one versus when the query is sent on the other. And when does the provider see the query on one of those workflows versus when does the provider see the query on the other. And once you start getting these things organized in your head at the time that they happen, it gets very useful for figuring out where to implement your mitigation strategies for things like unanswered queries and that type of thing. For instance, one of the really important things we noticed pretty quickly is on our ED workflow, the coding occurs much faster. So in our ED workflow, the CDS goes in and they take a look and make sure that the coding has not already been done. In this case, is final coded and closed, because there's no point in us sending a query at that point. This case is closed and we're not reopening it to do all that stuff. So we don't want the CDS wasting a lot of time going through that chart. If it's already been coded and closed, we wouldn't serve any purpose. So that's just kind of one example of the reason that it's important to go through these workflows and get a really good idea. Another really good use for workflows is it also allows you to design your training, and it gives people that are newer a guideline to follow. And you'll see, if you're looking at these workflows here, you'll see that it also says things like see Appendix A or see Appendix B. And when you get in those appendices, that's when you get the more specific to your particular process. And it allows these workflows to also be scalable or adaptable to new packages and that sort of thing. If you're changing software or changing parts of your process, then for instance, if we're looking at how to record the query, we just change whichever appendix talks about how the query is recorded if we were to switch software or something like that. Okay, so I think Shirlivia mentioned Tableau earlier. That screenshot that you see over there on the right, that is Tableau, and that's just a view of some data that we had in Tableau. The reason that I chose this particular slide is I wanted you to see that as our program has been evolving, even the way that we're looking at it is changing. And you'll see January through December at the bottom of that picture. And you'll see that when we got to October, we noticed a change in there. And part of that change is what we were looking at is a way to measure our productivity. Before, when we initially started, all of our CDS team had their own individual spreadsheets, and they were tracking and doing their notes and that sort of things on their patients, trying to watch their new visit and stuff. But we didn't really know who's seen which patient or what unless they sent a query. We had a place where they're recording queries, and so we knew how to get to it from that, but we didn't really know, well, how many patients are you reviewing? So we have an idea of how many patients is reasonable to expect to be reviewed. So what we did is we kept modifying our in-house database that we had, and I'm going to show you more of that in the next slide. I'm just going to review my notes real quick and make sure I touched everything here. Okay, and the other thing, the reason that we use Tableau versus something else is we already had it. We didn't go out and buy this to do it. It was something we already had, and I had access enough to have creative control on it itself. And for me, having creative control is a lot more important because I can move a little bit faster when we're developing. So this is our in-house database. Now, you don't have to build an in-house database. This is the way that we chose to do it. On the left-hand side of this slide, you'll see a form, and that form is for entering a query, but also you'll notice I got a red box around review only. So we had this form for a long time, and everybody would go in and record their queries, and we thought, well, why not just add a review type of review only, and then we can use that to give us a kind of a productivity measurement. So we can see how many do you review versus how many you actually end up sending queries on. And each one of these blanks that's on this form that you see right here, these are all good data capture points, and we're going to touch on this over and over again as we go through this presentation. As a matter of fact, our presentation will seem a bit circuitous to you. It's a cyclical process. A query itself is linear, but the process itself of having the program is going to be a cycle. And so we're going to go back and we're going to cover things more than once as we go through this presentation. On the right-hand side, what you see is the view after I enter a query, and you'll see each one of those column headers is the blanks that you see on the form that's on the left. Some other considerations that we had are how, if we're asking our team to do extra work, then what are we giving them in exchange? So now we're asking every single time you go and review a chart, we also want you to go and record it in this in-house database. Now this database is accessed through a web page. So that means they have to stay logged into this web page all day long as they're doing their work. And they have to enter every single query or every single review that they do. So we came up with some ideas for making this part even faster. And these are all evolutions that occurred as the program was going. But we added searches where you could search on a particular MRN. For instance, if you left some notes on an MRN and you wanted to go review those notes, you could put that MRN in and search them out real quick. You could change the filter where it says CDIS to your name, so you're only looking at yours. You could change the filter where it says response and just filter down, say, for ones that just say no response. And then finally, we added one for diagnosis coded, and we'll kind of get into that more later in the presentation if we have enough time. Okay, so we talked some about KPIs and workflow, and we talked about our first KPI that we wanted to improve was our productivity. Well, we had to figure out a way to measure it before we could figure out a way to improve it, right? So another thing we thought was pretty important is we were capturing all these different data points, but we needed to say what kind of questions are we wanting to answer here. So for response, we were like, okay, well, what did they answer? Or did they answer at all? I don't know how many of you guys get a lot of get unanswered queries, but for us, it was an issue. We were able to see, for instance, when we looked at a year's worth of data, we had 888 that were unanswered queries. So we had to come up with ways to combat that and see if we could work that down. And then we also were talking about how long did it take to answer. So maybe it was too hard for the provider to see the query. Maybe they just needed some education. Or maybe the CDIS needed education to make their query more applicable. These are all questions that as we were capturing the data and looking at these data points, we could dig deeper and try and get a better idea. But one of the biggest things, and Sherlivia touched on this earlier, is we saw, wow, we've got a lot of unanswered queries. So we wanted to say, okay, well, we need to tackle those unanswered queries before we worry about their turnaround time. And so we went and we looked at whichever clinic, and I'm not going to call out any of our clinics, but we looked at whichever clinics had a high rate of unanswered queries, and that's where we decided to focus our first efforts. So Sherlivia talked about stakeholders and stakeholder assistance and office staff in particular. So there were two things that if you're an office staff member that you're going to care about. One is there a query? And two is, did the provider answer the query? Now, in the screenshot that we show here, I show several different clinic names, but the design that we did allows us to actually filter to a particular clinic name and then automatically email the same view that you see here to that clinic staff manager. So at the top, they see the queries that are pending for this week. Now, this is for our outpatient clinics, not for our ED, because the outpatient clinics are prospective. So these queries are already recorded in our database because they've already reviewed the chart before the physician has, and they've submitted them. And our team gets them in at least 24 hours before that visit, so that in the morning, first thing in the morning, when this email sends out, that query is already in the database. The other thing, the question that they are interested in is from the queries that you got last week, did every provider answer them? So again, it's filtered down to just the view of their clinic. So instead of seeing on my screen, you see here several on the right-hand side, theirs would just show their clinics and whether they had outstanding queries that were pending this week or unanswered last week. Okay, so then we talked about, we just showed you how we came up with an automated process for the clinics themselves. And then I mentioned earlier the coding aspect of it. Now that's one of our other stakeholders that Shirlivia was talking about. And what we determined is that our team with those individual Excel files, going back to the beginning when we were talking, they were also recording whether coding captured the query once a physician had agreed. Now, since we were already capturing this data in our database, we thought, okay, well, we can probably automate some of this. So before, at some point, they would compose an email and then they would copy and paste that list of the uncoded queries and send that out to the coding team. So what that means is if you're the coding team manager, you might get 6 different emails, because we had 6 different team members with each team member's uncoded cases. And I didn't really have a really standard day or time of when they were doing this stuff. So these are all things that we started identifying as we're doing the workflow, and we were able to kind of fine tune them to be a little bit more efficient and more regulated about when they all occur. So we thought, okay, well, we created an automated process showing whether we had pending queries or unanswered queries. So why don't we just create another automated process? It's connected to the same data and it's really just designing a different dashboard. But instead of our team having to worry about these emails and stuff, just in there, they go into that tool that we showed earlier, and where it says diagnosis coded, they just mark it as no. And then we have an automated email that occurs from Tableau, filters to the view that's of interest. For instance, we have an ED coding team, so it would filter to only queries that say ED query. And then we have an outpatient clinics coding team, and it would filter to only views that show outpatient clinics. And those email subscriptions go to those particular managers or users in those units at the date and time that they ask for. And so we just talked to our team and said, okay, make sure you record your stuff by this certain time because the rest of it happens automatically. Okay, oops, let me go back one more. I had one more thing I wanted to say on that. Okay, I don't want to give you the impression that all this was easier, that it occurred quickly. We actually spent a lot of time developing before we ever started enlisting our stakeholders. And Shirlivia touched on a lot of this, particularly the workflows and the design of the education or the appendices and that sort of thing. And then we spent a lot of time discussing which stakeholders would even be able to help us. And then we discussed, okay, what is in it for them? Because before we go to those stakeholders, we've got to have our quid pro quo, right? Tit for tat. If I'm going to give you something, then what is it going to give you in return? What do you get from this? So in the instance of when we were talking about the coding team here, I'm giving them one thing to look at and review about whether it was coded or not versus 6. And it's all really well laid out. And then they can go and research it at that individual dashboard even more if they want to. In the case of the clinics, what I'm giving them is I'm giving them an email that says, hey, you've got these pending queries, and if these pending queries get answered and your physician agrees, then you're potentially increasing your risk adjustment factor, which is what Shirlivia was talking about earlier. So these are really good selling points, and you need good selling points when you're going and trying to ask somebody to add something to their workflow. If you can add something to their workflow that actually decreases the amount of time spent in their workflow, then you have a much better potential of selling that new task to them. Okay, so this part is where Shirlivia and I start talking against each other, or over each other, or with each other, however you want to look at it. But we're going to talk about our EMR and how we started identifying some of the right information. All right, I'm thirsty, so you go ahead, Shirlivia.
Thank you so much, Reggie. And I think you hit the nail on the head. I think it's so very important when you're looking at your process and you're thinking about fine tuning or even launching, trying to think outside the box and how what you're trying to do will not only benefit yourself, but those stakeholders that you're trying to engage in your process. And it first starts with a conversation. And so thank you so much, Reggie, for mentioning that and bringing that back full circle, because that's so important. Our next piece of our presentation that we want to talk about is our EMR and capturing the right information. And we've talked a lot about asking the right questions. And I say that because we learned a lot about asking the right questions, because all of what you see here today, we did not do alone. And when we were asking for help, we had to present the right question that was meaningful to the stakeholders that we were reaching out to. And one of the things that we'll go through with you is actually our scheduled appointments and how that sits into the EMR, and who and how and what questions to ask to ensure that you can automate your system, because you've seen how our CDI team gets their work list, that Tableau database that you see. Not only do we capture data from that from a productivity viewpoint, where we see our agreement rates, our total queries we sent, what type of queries we're sending. We use Tableau for all of that, but also those scheduled appointments is joined to Tableau so that our team can get their work list or their patients that they need to review for any given time period.
I did want to state again for the record, neither of us works for Tableau. It just happened to be that our company used it and we had access to it, and so we decided to use it. But you could probably do a very similar process if you've got the overall workflow and understand where these things occur. You could do something very similar with, say, Microsoft Access instead of building your own in-house database and, say, Excel. Maybe you have shared Excel sheets and things like that. But there are some size limitations when you're working from Access and you're working from Microsoft Excel, and we were afraid that we would exceed those size limitations based on the amount of visits and things like that that we see and record.
Yeah. Yes. All right. So these are some of the components of the questions you may want to ask as you're looking at your EMR and whatever tools that you're going to use to maybe automate your process, or maybe the tool that you have today, depending upon where you are. Looking to see in your EMR where your clinic visits are, and your scheduled appointments, because that's so very important, because these appointments are scheduled a year in advance, right? So changes are ongoing. A patient can cancel. Maybe a physician cancels an appointment. So cancellations happen. The appointments are rescheduled. So it's important that you're tapped into where these scheduled appointments sit, so that you have an accurate list for your team to review ongoing. And of course, for us, we complete prospective reviews at least 24 hours in advance of the clinic appointment.
And that was something that we decided as the program evolved. As we were looking at it and stuff, we decided, that at least 24 to 48 hours gives us everything's been reviewed and put in there before the physician gets a look at it. Because if you put your query in the day after the physician sees the patient, well, the chances of getting that query answered are going to drop dramatically.
Yeah. Yeah, and even you guys heard a lot about how we're partnering with clinics and automating that process. So again, doing it in advance is key to that process. And Reggie talked a lot about how within our tool, how we look at if a diagnosis was captured or not, because there are processes in place where we ensure that if we're going to query for an HCC, it's going to be coded and captured on the claim, right? Because that's where the rubber meets the road. And so our team, the CDIS team actually owns that piece of the puzzle. But of course, we've looked into multiple ways and how we can automate that. And here is just some insight on things we review in Epic to review if a diagnosis was captured or not by the coding team.
And
Reggie, anything?
Yeah, this is one of those things where after Sherlivia came and we were watching people go through the workflow and how they did it, she and I discussed the possibility of, hey, if they're always going to this section of the chart and always looking to see when these HCCs were recorded, could we possibly automate that part? And that was another evolution that our original query that we did about the appointments took on. And so added to that query, not only were we looking at the patient's visits, but we also added whether they had an HCC recorded and when was it recorded. And then that allowed us to add a little flag to it in our Tableau dashboard that turned it to orange if, for instance, an HCC had been recorded in that particular section of that particular patient's chart in 2019, but had not been recorded in 2020, which kind of just, allowed our team to not have to dig into that particular section of the chart, because that part was always consistently the same, that process. So that's the kind of thing that you can replace with automation. So we replaced that, and that decreased the time slightly that our team had to go digging through the chart, but allowed us to trade that off for the additional time that we added for them recording every single review only case. So it gave us a trade-off to give them, say, yes, we are adding additional work to you, but look at this work that we took away that you don't have to do anymore. It's right there.
Yeah. And I think our EMR an important components here. We're just kind of going through the list here. For our billing and coding, we talked a lot about that and understanding the differences and similarities from what we do as CDIS, what the coding does, and asking these important questions. And again, we're trying to give you the tools that we had to figure out over time about asking the right questions, to get the right answers. And so this is what this slide provides for you here. And just that continuous cycle and feedback between every stakeholder that's a part of your process.
We're going to keep saying it. It's workflow, stakeholders, data capture. You got to have all those things to make this work.
And again, our escalation process is no different from any other escalation process that's, I think, used today in our historical inpatient CDI review process. But again, as Reggie said, we're continuously talking about those clinic managers and how, for me, they truly became my bread and butter. Like, I can reach out to the one we partnered with the most, and where we started to partner today, and I can ask her, because she was the very first one I partnered with. I've asked her, do you mind being a part of conversations with other clinic managers to help them understand our success and how we were helpful in your area and what you do and how you oversee your RAF scores. And so she was like, yeah, sure, Livia, I can help you. So again, this outlines some of the key things that we use in our escalation process, but partnering outside of your own department to everybody you touch, I think, is so vital in ensuring success.
I like to say follow up and follow through.
Yep.
You
there you
have
go.
to follow up. If you don't do your follow up, then people don't know that you're actually, going and following through with this. And then there can be this feeling of, well, why am I doing this if nobody's ever following up with me? Well, I have to follow through, and once I follow through, then I make sure I follow up with the team and say, here's the results of what we were doing. And so here are some results of what we were doing. As Olivia was just mentioning, we partnered with a particular clinic, and this clinic you'll see in October, just in their family practice had 12 unanswered queries. And then the first week of December, we had a meeting with that clinic manager, and in just that one clinic, our unanswered queries went from 12 down to 3. Now that's brand new. That process had just started in November or in December. So our data right now might be a slightly different from that. I haven't looked at it today, but we did see a dramatic improvement right away. Now what we will do is we'll continue to follow that up, because we want to see if that's just that, I forget what they call that effect, when everybody's looking at it and it adjusts. Do you remember what that's called, Olivia? In lean daily management, like if everybody's focused on something. Anyway, if everybody's looking at something, that you get that natural bump down all of a sudden, and then we want to see if our process is efficient. whether it stays down or not, or whether it bumps back up. And that's what one of the ideas behind follow up and follow through is.
Yeah, thank you, Reggie. Continuous review and measuring what you put in place. It doesn't stop, right? We talked about out of sight, out of mind. Same thing with anything you do. If you don't continuously review and look at ways to improve it, it can fall apart. And so this is just our deeper look into our data that we were capturing. I think because of outpatient CDI and canceled appointments, looking at how we were actually measuring our agreement rate was important. And this slide is just a highlight for you that, for canceled appointments, we put it in a certain category to ensure it wasn't captured in our overall agreement rate, because an appointment, a CDIS can complete a review and an appointment is canceled the day of. The review is already done if we're doing it 24 hours in advance, but we don't want to delete that information from our database because a review was done. A query may have been sent, and that's an important productivity measure for us and for CDIS, but it shouldn't be counted in our agreement rates. And so this is what this slide outlines.
This particular slide here, this is connected to that same database that we've been talking about all this time. But what you'll notice on the left-hand side is you see the ED query volume, and on the right-hand side, you see the outpatient CDI query volume. Now, you think, well, they look exactly the same. Well, yeah, they are designed to look the same, because this way, when you're presenting your data to, say, your upper level management or to our manager or something like that, the view is very similar. They're used to reading this view. And so it's very easy for them to adjust by, just looking at the particular numbers. Now, on the background, this goes back to what Sherlivia was saying before. The workflows are different for ED and for outpatient CDI. So when we're doing the calculation of a turnaround time for ED, for instance, is going to be a little bit different than a turnaround time for an outpatient clinic. But we can still create consistent views that are good for showing to your managers and when you're looking at your KPIs and stuff. And this ties back into scalability, which we talked about earlier. Because we're designing these same types of views and stuff, we're reusing a lot of data, reusing parts of our dashboards and things like that. And in this particular instance, you'll see that this dashboard really just has a toggle between ED and outpatient, and we can switch to those views. Or our manager could look at both of those together and see what the entire outpatient clinical documentation integrity program statistics look like, as far as the volumes of reviews that they're doing and the volumes of the agreement rates in particular. That's something that they're very interested in. This one, Sherlivia, you want to talk about this one, because this helped us decide a couple of things.
Yeah, this is high level, all of our top 25 queries. When we're looking at this, again, we're looking at our clinics. We filter down through our clinics in line with our MSSP patient population. And we just kind of wanted to give you guys the overall view of what we do capture in our outpatient CDI program within the database that we utilize.
So I think that what's important to say on this is we could take this and we see, okay, we've got mental health diagnosis is way up there. And then we can slice and dice the mental health diagnosis. And then we might be able to go and look at an individual doctor and see that, a big chunk of those mental health diagnoses are just to that one doctor. And then we might say, hey, is there something, are we missing something? Is the doctor missing something? And it kind of help us use that data and make that data more effective. Data is a great tool, but you have to use the data. And in our case, this let us see where our bang for the buck could be with particular diagnoses, and then we could slice it up by particular clinics and kind of see which way to go.
And here's our RAF score. This is an important measure that we can see and measure, and you can see our calendar year 19 versus our calendar year 2020, and the total patients that's included in that RAF score. So I know we had a question early, can we capture this information? And yes, we can, and we do this in a different tool.
And that was during a pandemic.
Yes.
So why do we do that? We did it because of this right here. the overall KPI that we were trying to align ourselves to, we had multiple KPIs rolling up into it, but it was this RAF score right here. We were trying to hit that RAF score, and we hit it. Well, if you round it, if you took off one more decimal point, we hit it. So what did we do to win this race? Well, we improved our workflow, which allowed for standardization, and also the physician response selection. We standardized our physician response selection. We actually aligned pretty closely with what the inpatient responses are and with what the inpatient choices for templates that they use for what type of thing that they're querying about. We're very close on both of those, which also is very useful for our upper level management. The more similar things appear, then the easier it is for them to organize it all in their head and follow similar stats for it. It allowed for implementation of standardized escalation processes, and that's just going to help you. If you have standardized escalation, it's just going to help you for being consistent throughout, and it's a little bit easier to monitor the more you can standardize that stuff. It updated our tracking ability for our data integrity. So we've shown this several times throughout the presentation, but the reviews, the queries, and the volume are all tracked, and we can easily flip that around and look at a month, we can look at a year, we can look at fiscal quarters and all that sort of thing. So our data is very dynamic. You could do the same thing with an Excel sheet. You would end up with a lot of multiple, you'd have multiple Excels that you'd have to do that sort of thing, but you could do it. We added the HCC capture preview, and that's what I was just talking about earlier, that made it a little bit easier so they didn't have to open that particular section of the chart that was already captured. Anything that's like that, that's a standard thing that's always in the same place in the chart, that's something you can look into automation of, because those types of things are repetitive tasks, and a computer can do that for you and save your skilled labor for the things that is going to take their own, their experience and stuff to work out. Some opportunities were identified by escalation. The physician education on answering the queries. I showed you that we had 800-ish unanswered queries in a year. We worked a lot on minimizing our query size to decrease distraction. And we even decided to focus on the more important, like if you had 2 HCCs and one of them wasn't necessarily one that's going to pay well, then maybe it's a better idea to just send one query for one HCC. And if you can get that one query answered, you're going to get a lot more bang for your buck than if you send a query for 3 different things and they just ignore the whole thing. Then standard dot phrases, that's a particular thing to Epic, but almost every single EMR has something similar to that, and that's when you're documenting in their documentation, and they can have a standard for that. And then this is our last slide. So this one, we say you can succeed. Just pick your way that you're going to target your population. We used MSSP, but maybe you want to do all Medicare or something. It's just going to depend on the size of your team and the size of your visits, how many total visits. Pick your team. Sherlivia talked a whole lot about picking your team. The stakeholders, very important. It's huge. You got to identify who your stakeholders are, but before you ever contact them, make sure you've got a pretty good idea of what your program is going to entail, how it's going to work, and definitely before you get to those final stakeholders like the physician's offices and that sort of thing, you've got to have your process solid and in place, and you've got to have vetted your data very well. Plan your data capture points, which is going to help with that. Design your preliminary workflow. Focus on automation. Automation is huge. Anything you can automate is going to save you time. And above all, be flexible. The data may change, the workflow may change. Just keep working your plan.
Thank you, everybody, for joining us today. I hope there's some pearls that you were able to take from our presentation today.